I'm speaking to you on the background of the International Myeloma Workshop in Vienna in September 2021. I will be participating in a debate here on which immune approach in myeloma is most likely going to replace autologous stem cell transplant. So there are two major immune approaches in multiple myeloma that are emerging as blockbuster treatments for patients. These are one, CAR T cells against BCMA, and the other approach is bispecific antibodies, which are generally a BCMA CD3 bispecific antibody in the category of teclistamab or TNB383B, etc. Both of these are capable of producing a large number of responses, even in relapsed refractory myeloma patients, and sustaining those responses over time. However, there are fundamental differences between the two approaches. CAR T cells are tedious. They are generally a one and done approach where one treatment similar to a transplant is done and further maintenance strategies have not, at least at this time, emerged. And following that, the majority of patients get into a MRD negative remission, and those patients tend to keep those remissions going for anywhere from 1 to 2 years or even beyond in some cases, especially for the exceptional responders. We don't know the mechanisms of relapse very clearly after CAR T cells. The bispecific antibodies, on the other hand, are given similar to any other monoclonal antibody treatment, such as daratumumab or Sarclisa or isatuximab. These treatments are repeatedly given at an interval ranging from every 3 weeks to every week. And their side effect profile, at least for the initial part, is similar to CAR T, but of a lesser grade of severity. But the repeated treatment can go on for many years as long as the patient is responding. Both of these approaches have their own risks and benefits. And also we need to ask the question, do they replace autologous stem cell transplant? Do they complement autologous stem cell transplant? Could they use to consolidate the benefit of autologous transplant? And how will myeloma initial therapy change in the future? Because all of these immune approaches right now are being tested in relapsed patients, and the treatment of patients who have never relapsed, or the upfront treatment, how we use autotransplant generally, that setting, immunotherapy is still in its early stages. So overall, I think it's going to be an exciting debate, and I request anyone who is in Vienna or following online to log into it. And myself and Dr. Ainsley will be debating each other about which approach serves patients the best in the future.